Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with a Doctor. My name is Dr. Gregory Leach, and this is a show, an educational show, where we interview experts, medical experts in their field, specialists. And tonight we have, I keep saying tonight, we used to do this at night. We have Dr. Raymond Phillips. He's a practicing gastroenterologist in Naples, Florida. And we're going to be talking about colon cancer in different ways. But Dr. Phillips, why don't you tell us a little bit about yourself and where you came from?
Well, thanks so much, Greg. Yes, thanks again for inviting me back. Well, I'm a gastroenterologist. I'm a board-certified gastroenterologist, and what that means is I went to college, I went to Princeton, went through at Princeton and graduated, and I was able to pay my way through with an Army ROTC scholarship. Went to medical school in St. Louis and Washington University. I graduated there. Went on to do internal medicine training at Jefferson Hospital in Philadelphia for 3 years, and then I was chief resident for 4th year. And at that point I went on active duty, and I was assigned to a place called Fort Leonard Wood in Missouri for 2 years as an internist. And then I was selected for gastroenterology training at Walter Reed, and was trained there for 2 years. And then I was on the staff at Walter Reed doing research and supervising training of other fellows for additional 2 years. So I mentioned all that not to be dull, but rather instead just to let you know that a gastroenterologist has on average 12 to 15 years of training, and we are experts in issues in terms of digestive diseases, any gastrointestinal issue from the mouth all the way to the other end, and then also liver disease, pancreatic disease, and also experts in nutrition. Only specialty that's an expert in nutrition. So we have a far ranging and encompassing specialty that is sometimes neglected and not emphasized when we speak with individuals. So it really is when you're speaking with a gastroenterologist or consulting with a gastroenterologist, you're really looking at an expert in a lot of different areas.
Well, I think it's probably going to become less neglected, especially with the onset of more information about nutrition, which is where everything starts. We have some questions from our studio audience that we can ask you about colon cancer. And one of the questions is, how much of a problem is this? Is this really overblown, or is it?
No, actually, colon cancer is quite an epidemic across the United States. It's the second leading cause of cancer deaths across the United States, both for women and men. And there's in the range of 50 to 60,000 deaths per year, and several 100,000 new cases per year. And over the years, there's been a gradual decline in the incidence of colon cancer that's been attributed to screening and perhaps some changes in diet. But it's a very, very common problem across the United States, and it really is an issue, a public health issue. Now, the difficulty is that for years we had relied on symptoms to alert us as to whether an individual needed attention, whether they needed to be evaluated, symptoms such as bleeding or change in bowel habits or abdominal pain. But our experience was such that if we relied on symptoms exclusively, oftentimes if there was a colon cancer present, the problem was so far along we couldn't be as effective as far as treating an individual. Now, don't get me wrong, our treatment for colon cancer has really improved dramatically, but over time we were frustrated with our experience with treatment and searched for a better understanding of colon cancer, trying to find means of being able to intervene in a more timely way. And one of the things, in an effort to understand this illness more completely, we did a number of different studies in the 1980s and 90s trying to really understand how colon cancer evolved and developed. And what was learned and what has really been proven is that there's an evolution of colon cancer from a growth called a polyp, which is a collection of tissue that's growing faster than the surrounding tissue within the colon. And as that tissue accumulates and grows over the course of 4, 5, or 6, 7 years, sometimes a cancer cell can form within that tissue, and then that can emerge over a year or two's time into a full-blown cancer. But finally realizing there is that sequence of development of polyp and emergence into a cancer provide us an opportunity not only to be able to understand how to detect colon cancer at an earlier stage, but actually finally to be able to prevent a colon cancer from ever developing.
So you can prevent, how much is preventable?
Well, you know, the issue of prevention has been looked at in a two-pronged way. One general sense is, hey, what can we do on an individual sense to potentially prevent that? What can we do with regard to diet or medications that may be beneficial? And over time, you know, diet has been looked at as one of the more powerful factors with regard to the development of colon cancer. That's based on studies out of epidemiological studies where individuals have moved from, populations have moved from areas where there's very, very low prevalence of colon cancer like Japan, and those populations, when they relocate to the United States and eat a Western diet, within a generation have the same prevalence of colon cancer as individuals who have been eating a Western diet for generations. So that kind of observation made it clear that there was factors in the diet that are actually promoting the development of colon cancer. Now the difficulty is there's a lot of components to your diet and it's not easy to really identify what aspect of the diet is either promoting or preventing the development of colon cancer. It has been thought that certain foods, fruit and vegetables are beneficial, but there's been not enough consistent data to really show that there's a particular diet that will prevent a colon cancer. On the flip side, there are certain foods that have been shown to promote colon cancer in terms of high-fat foods, foods that are grilled. Those are examples of items that have been associated with a higher risk of colon cancer. But again, the association is not so convincing to say that you should become a vegetarian exclusively. So it's a difficult area, and in the area of medications, we've had a lot of promise in terms of using anti-inflammatory medications like aspirin as a preventative measure. But again, it's not so reliable that we can say that this will indeed prevent the development of colon cancer. So the other innovation, the other pronged approach that I was alluding to, is this notion of potentially evaluating the colon. Now that we had an understanding that there was an evolution and a long evolution from polyps to formation of cancer, the notion was, well, gosh, if we can find a polyp before it makes a transition to cancer and remove it, we could potentially prevent a colon cancer from ever developing. And those studies were finally concluded in the 1990s and showed convincingly that, yes, you can prevent a colon cancer if you remove polyps as they're evolving and growing. And the conclusion of those studies, which, by the way, involved thousands and thousands of people and hundreds of different doctors, really showed that around the age of 50 is when polyps begin to be more common or more prevalent in the population. And that's why there's this encouragement when people to get to be in that age group, when they get to be an adult, that it's useful to go out and have a colonoscopy or some type of examination done. The difficulty is that not everybody's terribly enthusiastic about a colonoscopy. And we've talked about before what a colonoscopy is. It's a flexible instrument where we can look at the entire extent of the colon or large intestine, and it's done sedated, so it's a comfortable examination. And it can be done very, very safely and rapidly. And that has become a widespread tool across the United States. But there are also other means of screening individuals for colon cancer that have developed. But colonoscopy remains our principal tool because it not only allows us to screen for colon cancer, but also prevent it. And I should digress for a moment and tell you what the difference is. When you screen for colon cancer, you're looking for a colon cancer at an early stage. When you're preventing a colon cancer, you're trying to actually prevent it from ever developing in the first place. And that's why the understanding of how a polyp evolves into cancer was so powerful, because by finding and identifying a polyp and removing it, you can prevent a colon cancer from ever developing. Now, many screening tools that were developed over time, and there's a number of non-invasive ways of screening for folks that have been developed over the years, testing for microscopic blood, hemocold testing, That was very, very widespread, became incorporated as far as the physical. The notion behind it was a developing cancer now would release or might bleed a small amount, not enough that it would be detectable through inspection, but could be detected through microscopic methods where we can detect microscopic amounts of blood. And then alternatively, that testing for hidden blood became complicated because, believe it or not, you can sometimes have gastrointestinal bleeding from other causes other than something like a colon cancer. You can have bleeding from, say, an ulcer or an irritation of your stomach or eating a rare steak. And so the notion is that we wanted to develop more specific ways of looking for or detecting cancers, and other methods have been developed, and we'll be talking about those soon.
So one of the questions that our audience had was, how reliable are the symptoms?
Yeah, symptoms have been, as I said, have been a disappointment, and in terms of symptoms in general, the kind of things that you would be concerned about would be bleeding, obvious blood, or in stool or on toilet tissue. But there's many other causes for bleeding other than something like a colon cancer, so it can be a little bit misleading as well. Changes in bowel habits, for example, where you might have something that changes the character or the nature of your stools that you have, can be an issue as well. And to the extent that if you have a developing cancer that's narrowing the diameter of the colon, that could intuitively, you'd think, hey, that would change how readily or how frequently or the appearance of your movements when you go to the bathroom. The troublesome things and a lot of other things can affect that. Changes in diet, stress, activity, and can all affect the appearance of a movement. So that's a very unreliable thing as well. So it's worthwhile to notice these things and report them to your physician, but they've been a little bit disappointing as early warnings for trying to be able to detect things at an early stage. Some studies were done on this, and reliably, that by the time you have clear-cut symptoms that you have a colon cancer, this colon cancer may have already begun to spread elsewhere in your body. So it's not a useful thing for being able to detect and intervene in a timely way.
So those would really be a late finding.
Yeah,
exactly. You really don't want to have any symptoms.
Yeah, exactly. You don't want to get to the point where it's really obvious to you got a problem before you sort of consult with your doctor. And that's why symptoms have been so disappointing. They shouldn't be ignored, but they shouldn't be relied on as an early warning of an issue.
And I had a question about scoping. The frequency with which you do a colonoscopy every 7 to 10 years, I think it is. How much of the cancer can you prevent? I mean, can you prevent all colon cancers by doing that?
And well, that's really
almost all.
Yeah, that is a really important question. That's a really important question because now that we understood that polyp to cancer sequence, and you would think, hey, if we can find a polyp, we can prevent a cancer. We could perhaps prevent all cancers in some way if you scope people frequently enough. And but the reality is, our experience as we began to implement colonoscopy on a widespread basis, we were not achieving the degree of prevention that we thought we should be achieving. And there was a great period of introspection in the gastroenterology community because now, since we're not achieving the results we'd anticipated, but it turned out that the reasons we were not achieving this is we were not doing a sufficiently adequate preparation of patients so we can inspect very, very thoroughly. And also, we were learning that all polyps are not created equal. There are a different variety of polyps. Some polyps are very precocious, like children. They grow up quick and they learn fast, and they have a sequence that's not spread out over 5 or 10 years. It might be over 1 or 2 or 3 years. Those, fortunately, are rare polyps. And then certain polyps can have a different appearance and escape detection. And we can talk more about that in a few minutes.
Yeah, well, we want to have the slow-growing polyps. We don't want to have the precocious polyp. We thank you very much for being on the show, and we want you to come back to teach us more about this subject, which I know you will.
Absolutely, Greg. We'll talk more about
Thank
this.
you for being with us today.